Next up is Dr. James Taylor, who is a clinical research scientist at Google. His seminar is going to be focused on technology to transform pediatric healthcare, unlimited potential, and big obstacles.
Good afternoon. As way of an introduction, I'm a pediatrician working as a clinical research scientist at Google, and I'm the editor of a newsletter type journal published by the American Academy of Pediatrics. It's always good to dampen expectations with a disclaimer. The technologies will transform pediatric healthcare, and the inflection points when their use will become standard will likely only be apparent in retrospect. Truly game-changing innovations are rare and sporadic. In addition to science and technology, there'll be gigantic social and political forces that will shape the future of pediatrics. Only a true visionary can understand all of these forces and predict the future. I'm not one of these people. So instead, I'll briefly describe some emerging technologies that could transform pediatrics, and based on my experiences as a primary care pediatrician, an academic pediatrician, and now 6 years at Google, indicate how they might be used to improve the healthcare of children, list some impediments to implementing these technologies, and offer some solutions. I'll talk about 4 types of technologies. First, there is the use of large data sets. This includes the way people interact with the internet, including Google Search, a tool that is used by literally billions of people to gather health information. Another type of large data sets are electronic health records, or EHRs. Using machine learning and neural networks, we can analyze the data in the EHR to streamline care, provide data providers in a more useful way, and predict disease onset. Wearables provide a unique opportunity to collect longitudinal objective health data on children, such as activity, heart rate, sleep, respiratory rate, and even oxygen saturation. Use of wearables is limited but growing, with about 20% of adults in the UK owning a wearable. Currently, use of wearables in children is minuscule. One concern is that because of their cost, unless healthcare organizations provide wearables to their members for specific use cases, there's the potential that use of these devices for improving health may lead to growing inequities. There are an incredible number of sensors on smartphones that can be used to collect episodic or longitudinal health data. The camera can be used to measure movement and calculate respiratory rate, as seen on this graphic at the right, and to generate photoplasmography or PPG signals for heart rate and oxygen saturation. With the smartphone's microphone, we can use algorithms to detect and count coughs and to assess cough acoustics to predict specific diagnoses. We can even generate a sonar signal to be used to measure respiratory rate. Accelerometers, gyroscopes, and barometers can monitor movement to measure activity and detect falls, and phones can include radar to measure heart rate and respiratory rate. Any talk on emerging technologies must include mention of large language models, or LLMs. LLMs can be used in pediatrics for conversational interactions for parents and by providers, and can be used for truly comprehensive analysis of the AHR and other data for disease prediction and monitoring. One prediction I can make with some certainty is that parents will have increasing autonomy in making healthcare decisions. Tools such as Google Search provide easy access to high-quality information. There are knowledge panels within Google Search which provide an evidence-based overview of the symptoms, treatments, and outcome for numerous pediatric conditions in easy-to-understand language. One of the things that we've done in YouTube, in partnerships with groups like the Academy of Medical Royal Colleges and the World Health Organization, is figure out principles for highlighting credible organizations who provide health information on YouTube. On the right, you can see how this works. Not only does Sheffield Children's have a YouTube channel, but we're able to help users see why it's credible, with a credibility cue that lets viewers know that it's from a UK healthcare provider, and a link to the WHO information about the underlying principles. Imagine this scenario in the not so distant future. A parent is worried about their child who has an acute respiratory condition. Using sensors on wearables and smartphones, they can get longitudinal data on their child's cough, respiratory rate, heart rate, and oxygen saturation. They can compare the trajectory of their child's illness against normative data collected on children of a similar age with a similar illness to either assuage their concerns or alert them that the illness is more serious than expected. As you probably know, validated nurse triage tools have been in use in pediatrics for over 30 years. But now with LLMs, the nurse or other professional may not be needed. Using LLMs and incorporating the passively collected health data, the parent can have an electronic conversation and, guided by the triage tool, get the best advice on whether symptomatic treatment is sufficient or if a healthcare visit is needed. If a visit is indicated, the child's data can be electronically shared with the provider in advance to aid in diagnostic and management decisions. Home sensors can also be used to monitor chronic conditions in children. This is a study in which an underbed sensor was used to collect data on heart rate and respiratory rate in children with asthma, and an algorithm was used to predict exacerbations. This could easily be replicated using wearables or smartphones to collect the information. With the proper algorithm, parents and/or providers could be alerted about an impending exacerbation, and treatment could be initiated to avert an emergency department visit or hospitalization. As you know, pediatrics has evolved from largely dealing with infectious diseases into a focus on the new morbidities, such as chronic disease management, behavioral and mental health, preventing and treating obesity, and the realization of the importance of social determinants of health. Current and emergent technologies can provide help in caring for these new morbidities. Behavioral and mental health is a hugely important part of pediatrics, with a behavioral and mental health concern raised at approximately 20% of primary care visits. Yet trainees have historically felt unprepared for dealing with these conditions. There are too few providers with expertise in pediatric behavioral and mental health, and the providers that are available are not equally distributed, leading to increasing inequities. An obvious use case for telemedicine is the establishment of regional systems for providing consultative and ongoing behavioral and mental health care for children. With such a system, primary care providers could easily refer a child to the network, and parents and/or the child could have access to behavioral mental health expert. Geographical constraints would be greatly reduced. The result would be better and more equitable care. There are also innovative uses for improving mental health in adolescents. Here is a study from researchers at the University of Washington in which a suicide attempt could be predicted up to 60 days in advance by analyzing participants' internet browser search history. Imagine if this were prospectively operationalized. After obtaining consent and assent, a parent and/or provider could be alerted when there was evidence from the analysis of a youth's search history that suggested severe depression. How many adolescent suicides might be averted with such a system? Another area of focus for the new morbidities is the understanding that many, if not most, chronic diseases in adults have their antecedents in childhood. There have been several recent studies on the association between step counts in adults and overall mortality, but promoting activity in children could have a much larger impact. Here's one of my favorite recent studies. The researchers measured activity levels and performed glucose tolerance tests at 3 different times in children 8 to 17 years old who are at risk for developing type 2 diabetes based on their parents' obesity status. They found statistically significant positive correlations between minutes of moderate to vigorous physical activity and insulin sensitivity, and significant negative correlations between sedentary time and insulin sensitivity. Wouldn't it be great for healthcare organizations to prescribe wearables for children at risk for type 2 diabetes, monitor physical activity and sedentary time, and try to promote behavioral change through standard techniques, automated coaching, or virtual in-person coaching? As we all know, behavioral change is hard. I've been trying to lose weight for literally half a century. If it was easy, I'd be a lot skinnier today. One innovative idea is using data from a use such as activity patterns, search history, geolocation, and social media use to develop a motivational phenotype so that the behavioral change interventions could be targeted for a specific youth to be more effective. Obviously, social factors are huge determinant of health outcomes in children. Here is a study in which an automated model was used to analyze EHR data and information from parents to identify children being primary care visit with significant social needs, alert the providers about the specific needs, and provide options for health. Using current and future technology, this could be scaled to better identify pediatric patients with one or more social need, and perhaps with the use of LLMs, help the parents and provider access the needed services. As I prepared for this talk and thought about how technology could transform pediatrics, it was rather amazing thinking about all the opportunities. However, I also thought about all the impediments to implementing these technologies. Unfortunately, it's a long list. For developers of new technology, there is a lack of large publicly available databases with health data on children to begin model development. There is a perception that there is an increase in risk in conducting clinical validation studies in pediatrics and implementing health innovations for children. As you probably realized during my talk, there is a tension between collecting data for health use and maximizing privacy. Something that I've learned about in the past few years is the concept of technical debt. If technologies are initially developed for adults exclusively, technical debt may be incurred by making it more difficult and more resource intensive to then retrofit the technology for children than if the technology had been designed for both children and adults from the start. Importantly, although the impact of improving child health in terms of increasing qualities dwarfs innovation for adults, the potential for generating revenue with many of the innovations in pediatric health is limited. All of these obstacles have a cascading effect and limit incentive for development of healthcare innovations for children. Overall, one of the major limitations to incorporating AI solutions is that generating algorithms that are accurate enough for use in healthcare is really, really hard. For a great overview, I recommend this article from Kelly et al. The lead author, Chris Kelly, is a neonatologist in London who works at Google. As is pointed out in this article, there is a risk that AI might increase rather than decrease health disparities. Finally, we really need to find that crazy, visionary genius who's in the right position and has the will to take the risk to use AI to truly transform medicine, particularly pediatrics. To end on a more positive note, here are a few modest suggestions for overcoming those obstacles. It would be great to have a working group of industry scientists, pediatric academic researchers, funders, and regulators who meet on an ongoing basis to both generate ideas for delineating the clinical utility of new technologies and provide insights on the type of new technologies that are needed to transform pediatrics. We should continue to change clinical training so that that training better matches the reality of pediatrics in the 21st century. Multi-sector consortiums may be needed to implement innovative solutions for children that have a significant impact but relatively limited revenue potential. I've talked a lot about the various data that we could collect on children in their homes and sought to illustrate how these data could be of enormous benefit to providers. But we need input from the various stakeholders on how best to share it with clinicians and healthcare systems. And perhaps most importantly, as a society, we need to develop guidelines on what and how to share personal data for healthcare use so that the most innovative possible solutions can be unlocked while preserving privacy. And with that, I'll stop and I'll be happy to try to answer any questions. Thank you.
Thank you to Dr. Taylor for joining us.